thank you, Veronica, for inviting me for this talk on hemophilia, especially on this occasion when we are celebrating the Hemophilia Day and the Hemophilia Week. And I think it is a very important and relevant topic for a lot of patients in India, because we have a very huge population who is suffering from hemophilia, and that too severe hemophilia. And I can only imagine their plight when they have to get their factors administered. Their lives are kind of compromised because they are not able to play contact sports. They are not able to engage into very aggressive activities. There is a lack of factor availability at most centers. The factors are very expensive for those who purchase them. The newer modalities are extremely expensive, and I can only imagine how anybody would afford that right now when only the innovator brands are available and we do not have generics for them. And also, the disability associated with this disease and the lack of expertise who can manage these disabilities is just compounding the entire problem and making things difficult for this population who deserve to be living a very good quality of life as compared to or similar to their counterparts in the West. And I'll just briefly touch upon the management aspects. And Veronica has nicely put forward the clinical manifestations of this disease. But I think the most important issue that comes in front of the quality of life of these patients is their joints. And with the recurrent hemorrhage, there is a synovial inflammation that goes on. And, when they keep on having these bleeds into their joints, they have this direct synovial invasion and enzymatic degradation, which eventually leads to an end-stage arthropathy. The arthropathy goes through three phases. First is the acute synovitis, where you have a lot of pain and swelling when it starts with, and pain is the main thing. And then it goes into a subacute chronic phase, and then eventually it leads to an end-stage arthropathy when these patients have got very severely damaged joints, and they are either wheelchair bound or they have to walk with crutches. They face recurrent fractures, and their quality of life becomes quite poor. The pain issue may go down as the joint damage increases, but the quality of life and the joint function is quite poor when they develop end-stage arthropathy. Hemophilic arthropathy can be extremely disabling, and that is the main target that we do not want our patients to have this. Target joints. What are target joints? Target joints, that is a particular joint that has experienced repeated bleeds. And US, Canada, World Federation of Hemophilia, they have all got different definitions, but it's basically a recurrent bleed into a particular joint, and that joint becomes damaged. Joint bleeds can happen in knee, ankle, hip, elbow, the shoulder, and also in the wrist joint. And muscular bleeds also can happen and can be quite disabling in these patients. And the real significant ones are the Iliopsoas bleeds. Iliopsoas bleeds can present with shock. They can have a vague pain in the groin, in the lower abdomen, and it may mimic appendicitis. And they may have difficulty in extending the hip, but the rotation is okay. And the hip is seen in internal rotation and flexion. These are serious bleeds. You can have damage to their nerves, like, femoral nerve may be affected because of the Iliopsoas bleed that happens recurrently. They can also develop Volkmann's ischemic fracture when they have it in the forearm. Gastrocnemius can lead to an equinus deformity because of defect in the posterior tibial nerve, and pseudotumors can also be formed. APTT is the most important investigation, and it gets corrected when you mix it with a normal plasma. That is, the mixing study corrects this APTT. If a mixing study is not able to correct the APTT, that means there is some kind of an inhibitor present. So whenever you look at abnormal APTT, the possibilities are factor 8, 9, 11. You can also have factor 12 deficiency. You can have von Willebrand's disease, or you can have APLA, or it can be a heparin contamination. You need to be careful whenever you are interpreting an abnormal APTT. When you are sure that your APTT is abnormal, you do a mixing study, and if it gets corrected, that means there was a factor deficiency. Then you go on evaluating based on the clinical scenario, and the most commonly that you'll pick is the factor VIII deficiency, which is hemophilia A. If factor VIII is normal, then you'll pick a factor IX abnormality, which is hemophilia B. Often we get samples which have been taken, 12 hours before, or, a sample test has been done, say, in a peripheral hospital, and the sample kept on lying in the ward for, say, 8-10 hours, and then you do the factor assay, you're going to get wrong reports. So you have to be very, very careful. So, it is important to clinically assess these patients and look for inhibitors when the clinical scenario prompts you to do an inhibitor assay. And for that, the main test that is done is the Bethesda assay. I'll come to that later. Aims of therapy, the principles of therapy are to prevent and treat the deficient factor, to use specific factor as far as possible. So in the olden times, they would just give blood, FFP, cryo. Now that is not the case. We want to treat factor VIII deficiency with factor VIII and not just give them blood or FFP, which can, lead to HIV, hepatitis B, hepatitis C, and all that. When you are in doubt whether there is a bleed or no bleed, better to treat. Treat before the diagnostic scan. You have a clinical child with a hemarthrosis. You don't have to wait for an ultrasound to tell you that there is a bleed. You have a child with a joint swelling and he's got a hemophilia. Go ahead and give the specific factor. Treat if there is aura. Patients can pick up that aura, and it's always better to treat them in a comprehensive hemophilia center. Who is the part of this comprehensive hemophilia center? So a pediatric hematologist, if present, would be ideal. If not, then a pediatrician with interest in hemophilia. A nurse who is expert at putting cannulas, a musculoskeletal expert like an orthopedician, a rheumatologist, an occupational therapist, a physiotherapist, a good lab, a psychology expert, a geneticist, a hepatologist if the patient has hepatitis B or hepatitis C, an infectious disease specialist if the patient has already had HIV due to blood product administration in the past. And sometimes we need the help of all the other teams like dentist, obstetrician, whenever you have a very tricky patient. Take care of the veins of these patients because these are the lifelines for these patients. You don't want to just keep blasting the veins because a junior resident is putting cannulas for these patients, whereas a senior most person should be putting the cannula because you want to save the veins because they may have to receive I don't know how many injections during the treatment. Use butterfly needles if possible. Never cut down into a vein, and always you have done a venipuncture, please give adequate pressure so that the patient doesn't develop a hematoma. So you have to be very careful. Coming to management of bleeding, all of you should know the full form of this acronym called PRICE. Protection of the joint, rest if a child has a bleed or a swelling, ice application, compression, and elevation. So this is extremely important, and we teach all our parents the full form of PRICE and tell them to practice it whenever they have a patient. Now, direct ice application for children may be a little, annoying, or they might not like it. So you can just wrap that ice and crush it, and then kind of give ice compressions on a towel as well, so that the patient is not very much affected by the the cold temperature. So that is the basic thing that a patient can do. A peripheral pediatrician or an adult physician who sees such a patient can do. Please do not put in a needle in the joint to find out what is happening. If any orthopedician is listening to this telecast, I would request them that whenever you see a swollen joint in a child or an adult and you are suspecting that there can be a bleed in it, make sure that you have tested a APTT before doing putting in a needle. Take a good history. Maybe there is a family history of a bleeding disorder. We see patients who come with, life-threatening, very, very bad bleeds, damaged joints, septic arthritis, just because, somebody kept on putting needles into the joint and tried to aspirate that blood, and that blood bleeding never stopped, and the hematoma actually worsened inside the joint. Managing the acute bleed needs factor replacement. You may use antifibrinolytic drugs. You need to give pain management to these patients because pain can be excruciating, and then initiate a graded physiotherapy. So 1 unit of per kg of factor VIII increases the plasma level by 2%. And this is a simple formula that everyone should know. The half-life is somewhere around 8 to 12 hours. 1 unit per kg of factor IX increases the plasma levels by 1. And that is why the dose kind of changes from factor VIII to factor IX depending on hemophilia A or hemophilia B. The half-life of factor IX is relatively longer than the hemophilia A. So, this is a rough kind of the dosage pattern of what is the desired factor level. So for mild hemorrhage, factor VIII, we want to go up to the dose of 20 to 40%. But in developing countries, where the factor is so much less and it is very expensive and patient has to pay out of pocket at many centers, even desiring a 10 to 20% is okay. But for life-threatening severe bleeds, the ideal target is 70 to 100%, but we always target at least 50% for these patients to save their lives. And this can be like a major surgery, trauma, intracranial bleeding, severe GI bleeding, and Iliopsoas hemorrhage. And these can, in a patient in a state of shock, and you need to get the factor levels high as soon as possible. How much factor, how long? You can take the image of this recommendation, or you can just go on to the World Federation of Hemophilia website, where you can get the beautiful guidelines, and all the doses and everything has been explained very well in that. So usually they will give you the desired level that you want for a particular patient, and then you can calculate the doses. So how much dose to be given? So take the weight of the patient, the desired rise that you will know based on the type of bleed, and multiply it by 0.5 in cases of factor VIII, because it only this thing raises by 2%. So that is why you can just halve the dose whenever you are using factor VIII. And about the half-life, and a slow IV push can be given. In the absence of inhibitors for a patient with factor IX deficiency, you take the weight, the desired rise, and multiply it by 1. That is the same dose. And half-life is 18 to 24 hours. And again, a slow infusion can be given. Allergic reactions may happen to factor IX, and you need to be careful about that. So whenever you have a patient with joint hemorrhage, remember price, avoid weight bearing, and give rest to this patient. Give the factor replacement, and for next 2-3 days, 4 days, depending on the improvement, and then gradually go on to the rehab process, and avoid joint aspiration unless you have a hematoma which is completely not resolving, and you can do this under the good cover of factor VIII. CNS hemorrhage is a medical emergency. I have seen patients who are known cases of hemophilia coming to emergency with seizures, and the emergency doctor just is doing APTT, waiting for the APTT result, waiting for the CT scan, and then deciding whether I should give factor or not. Please do not do that. If you have a child with hemophilia A, give factor VIII immediately, because most likely the cause of seizure in this patient is going to be an intracranial bleed. Give the factor, take the patient for a CT scan, do whatever investigation you want to do. But what is the point of doing APTT? If he's a known case of severe hemophilia A, his APTT is bound to be very, very high, and it will remain like this forever. So you don't have to keep cross-checking it. Parents will be aware of this. We always advise them to keep factors available in their fridge, and whenever they have a medical emergency, we tell them कि आपके घर में जो भी factor पड़ा है, whatever factor is there in your fridge, please take it along with you to the emergency department. Before the factor is procured from the pharmacy or wherever, at least one shot of the factor can be given, and this can be really life-saving or joint-saving for these patients. What are the products available? I will not go into the details for that, but the older traditional products were the plasma derived, and then came the recombinant factors, and the really, really old things were the FFP and the cryoprecipitate. Tranexamic acid, EACA, desmopressin are kind of adjuncts for severe hemophilia, but for mild hemophilias, these can be really good agents, and we can avoid using factor administration. Tranexamic acid, the dose is usually 15 to 20 mg per kg per dose. And for oral bleeds, we can crush the tablet, apply it locally, or mix it with water, give them like a mouthwash, and this kind of helps in controlling the small oozes. Desmopressin, again, the availability is an issue in the particular dose that we need. We have the availability of desmopressin for nocturnal enuresis, but unfortunately the desmopressin which is required for hemophilia, that the higher dose ones, are not easily available. If factors are not available, you can use a cryoprecipitate for cases of factor 8 deficiency, but cryoprecipitate does not have factor 9. So what you have to use is a cryosupernate or an FFP in cases there is a factor 9 deficiency. This is really dire situation because the factor levels are very low, and you are unnecessarily giving them blood products which are not required, and fresh whole blood is definitely discouraged for these patients. Certain tips: nasal packing and antifibrinolytics are very helpful for epistaxis and oral mucosal bleeds. Remove the pack with soaking in saline 24 to 48 hours later, and no antifibrinolytic in cases of genitourinary bleed because they tend to form small clots in the ureters, and then you can have clot colic. So the pain can be severe. So we avoid tranexamic acid whenever there is a genitourinary bleed. Also, when you are doing a lot of hyperhydration, avoid desmopressin because that can again further lead to can lead to fluid overload. Now, chronic hemophilic arthropathy or synovitis are a totally different ball game. They need to be managed in expert hemophilia centers with orthopedicians, physiotherapists, and pediatric hematologists who are experts in hemophilia management, or adult physicians who look after the adult hemophiliacs and are tuned to or abreast with the latest knowledge of managing these patients. Now, coming to the aspect of prophylaxis. So we give factor on demand whenever there is a bleed, but that is not the ideal thing. If you want to prevent joint destruction, if you want them to live a good life, the ideal thing would be to give factor prophylactically. So say factor 8 needs to be given at least 3 times a week intravenously for the rest of their lives. And I know it is like asking too much, but if you give prophylactic factor 8, the joints are in the best possible shape. Now, I understand that is a big challenge in a country like ours, but trust me, there are patients even in India who are on prophylaxis and are living and enjoying a good quality of life. Now, the prophylaxis can be further divided, and I will come to that. So see what is happening when you are giving prophylaxis. So when you give a factor, you can see the level of the factor goes up, and within 2-3 days the factor goes down again. So when you are giving another factor, the level again goes up. So what you are trying to do is convert a severe hemophilia into a moderate or a mild hemophilia by administering the factors regularly in a patient so that he never drops to the level of say 1% or 2% and can less than 1% and can injure or even have a spontaneous bleed. So ideal thing is prophylaxis. Okay. Now prophylaxis can be of different types. So what happens in India for most of the patients, it is just episodic treatment. Whenever they have a bleed, they'll get factor. And this will lead to joint damage eventually because you will keep having, spontaneous hemarthrosis again and again and again. Now, ideally, the prophylaxis should be started before the second joint bleed. So you have one joint bleed, you know that this patient has severe hemophilia, and you put that person, that little baby, 1 year, 2 year, 3 years on a prophylaxis. This is called primary prophylaxis. Now, sometimes the prophylaxis is started after second joint bleed because patient does not agree. How, they have just had one joint swelling. Why should I go put my baby on an injection for the rest of the life? So they don't accept that. And it is very, very hard. So, sometimes it takes 1 or 2 joint bleeds for them to start the prophylaxis. And then sometimes the prophylaxis is started after joint disease has already started. That is called tertiary prophylaxis. So, and truly speaking, most of the patients are on just short-term prophylaxis here and there and not taking regular. And in fact, most of them are just on-demand therapy. That is, whenever they have a bleed, they'll take factors for 3-4 days, and then they will hope that, they will not bleed again. But unfortunately, severe hemophiliac will bleed again within 2, 3, 4 months. And again, they will be taking 3-4 days of factors. So, this is the kind of how factor administration is given in these patients. And ideally, the factor administration prophylactically should be started before the joint disease has started. So this classification is very important, and this is just the same thing in a text. So what are the needs for a prophylaxis? You need uninterrupted supply of factor. That is the first thing. You need to have that factor supply. And in all the Western countries, the government gives them free factors for prophylaxis. And their quality of lives are just amazing. And the parents are taught how to give factors. All the mothers, fathers, they will give factors at home. So they don't have to go to the hospital. The parents are taught how to identify veins, how to cannulate, how to give the factor. And there are like beautiful training programs with nurses going to your home and giving you training and educating you how to cannulate the veins and give factors. And this is a reality. Don't think that this is something, I'm just making it up. It happens in most of the Western countries. If you do not, or if you are not able to do it, you need trained person to administer the factor. You need good venous access, so the veins have to be handled very carefully. You need that motivation, that drive, and not just wait, 3-4 months mein 3 days lagana hai factor, 4 days lagana hai, we'll just cross the bridge as it comes. And training for home administration would be an ideal scenario. So it's not very easy to do a prophylaxis. And there are differences between hemophilia A and hemophilia B, and I will not go into the details for that. You already have been told about the half-life differences, but even these patients, the reactogenicity in A and B is a little different. And for the sake of time, I'll just move on to the next slide. Now, some newer things are happening in the lives of hemophilia patients because science is just progressing with every day, and we have very many new interesting factors that are available that are changing the lives of children with hemophilia. So if you have to give a factor, say 3 times a week, obviously your life is going to be tough. But if you can make it 2 times a week or even once a week, will that not make a big impact in the quality of life? It will. So there are ways to prolong the half-life of the factor, and a polypeptide extension, an altered protein structure by a mutation or glycosylation, fusion with other proteins like albumin and Fc gamma fragment or a VWF fragment are some of the ways. But what is now available to us is pegylation of the factor and the pegylated product. So pegylation is like a tail attached to the factor, and that just makes the factor stay into the body for a longer time, and it is not just excreted out quickly, and that improves the half-life, and your usage of factor quickly goes down, and you can increase the gap between the factor administration. One of them is turoctocog alpha pegol, which is the factor 8, which has been kind of clubbed with a pegylated technology, and that is leading to better half-life of the product. And similar way, there is a factor 9 product also now available. They are very, very expensive, but I'm sure the cost will go down. A lot of them are available through clinical trials, and these factors can be really life-changing, because you can see how the pharmacokinetic property changes, and you can see the white one is the newer product and the blue one is the older product, and how the half-life changes by using these pegylated molecules, and these patients can have a better quality of life. So you will have a better pharmacokinetics, you will have elevated trough levels. So you will not go down to that 1% or below 1%. It reduces the dosing frequency, reduces the bleeding rates, improves the target joint, and then you will have a better quality of life and a better compliance. Now, that is one aspect. but the life is not that simple. So what happens is that because these are foreign products, the factor 8, factor 9, you tend to develop autoimmunity towards them. So your immune system recognizes that this factor 8 is not your indigenous factor, it's come from outside, and you develop inhibitors to these factors or antibodies, and which you can check by doing a Bethesda assay. So there are technical ways of how you do the Bethesda assay, but Bethesda assay will tell you what is the titer of the antibody. These IgG antibodies neutralize the clotting factors and make your factor replacement ineffective. 20 to 30%, and even Veronica mentioned that, of severe hemophilia A patients develop inhibitors to factor A, and that makes management very difficult. So, whenever you are using the factors which used to help you before and now they are not helping you, or by a routine screen once a year, you have found out that you have inhibitors, these patients become very difficult, and you have to use special agents or very high doses of factors to kind of control this. So these special agents may be bypassing agents which are used, or you may have to use very high doses of factors. These inhibitors can be low titer or high titer inhibitors, and these low titers can be further classified into high responders or low responders. And there are definite algorithms as to how you manage these patients. You can use high doses of factor 8, especially when you have the low titer inhibitors. When you have the low titer with the high responders, or you have the high titer inhibitors, you have to use agents like factor 7. So factor 7 comes at the bottom of the clotting pathway, so it kind of just bypasses 8, bypasses 9, and just brings the coagulation, and it is very extremely expensive and has got a very short half-life. So the therapy becomes very costly. And similar way, another factor is called FIBA, which is used, again, it's a bypassing agent, and it kind of bypasses the 8 and 9 step and helps you to bring the clotting. So there are algorithms which people who manage hemophilia kind of refer to whenever we have to manage these patients with inhibitors. The new thing, again, other than the extended half-life factors which I talked about, is monoclonal antibody and its role in hemophilia. So the drug is called emicizumab, and you can see that this beautiful molecule sitting here, it kind of comes and binds to 9 and 10. So you have a severe hemophilia A, so you do not have 8. So this emicizumab, the bispecific monoclonal antibody, kind of comes and joins the 9 and 10. It activates the 10, and by activation of 10, the thrombosis cascade is initiated, and you develop clotting in the patient. So if suppose you had factor 8 in your body, you can see that here factor 8 is sitting on 9 and 10 and causing the normal clotting. But in emicizumab, when you do not have factor 8, by usage of emicizumab, you do not need factor 8, and if you have inhibitors, say towards factor 8, and your factor 8 administration is becoming kind of useless, then what you can do is give emicizumab, and instead of that factor 8, and even if there are inhibitors, it doesn't matter, the emicizumab brings 9 and 10 close, and you can have the clotting that is happening. The other advantage of emicizumab is that it is given subcutaneously. So, easy. You can give it on your own at home. It is very, very expensive, but I'm sure that with time, the cost is going to go down. So there were a series of trials, and very beautifully done trials, randomized trials, and I'm not going to go into the details. Haven 1, 2, 3, and 4, which kind of established the role of emicizumab both in treatment and prophylaxis, with inhibitors, without inhibitors, in adults and in children. So that is something really nice, and you can see how with the emicizumab prophylaxis, the beautiful reduction of the bleeding that is happening, but the cost is definitely a very big limiting factor. The first one was on inhibitor patients, the second trial was on pediatric patients, third one is patients who do not have inhibitors, and fourth one was to look at 4 weekly regimens, so higher dose given once a month, and how you can have a bispecific antibody kind of just taking out the role of this 3 times a week administration of factors into the vein, and that really improves the quality of life. It can cause thrombosis. The cost is a big issue, and lab assessment also is a big challenge. Now there are some other newer modalities which are being looked at. So now here we are trying to bring the clot, okay, and make a clot. The other way of looking at hemophilia is that you remove the things that kind of dissolve the clot. So, lowering of endogenous anticoagulants such as antithrombin or tissue factor pathway inhibitor with antisense RNA technology, which is called fitusiran, or a monoclonal antibody like concizumab. These are the newer agents which are being tried, and they have got some success in hemophilia A and B patient, and we just need to watch the space. They can be associated with increased thrombosis risk, and that is something that we need to look at. Last but not the least is gene therapy. So we just fix the gene so that the whole misery is gone away, and we use viral vectors to do this. And there has been a lot of revolution by the usage of adeno viruses, which have kind of replaced the older type of viruses, viral vectors, which were causing a lot of problems and side effects. So AAV viral vectors have brought in a lot of revolution in the field of gene therapy. So they are inserted with a factor 8 or 9 gene forming cassette. They are injected either intravenously or into the liver through a hepatic artery, hepatic vasculature access. The risk of mutagenesis is supposed to be low, and the early results are actually very encouraging. And you can see the number of trials that are going on in the West on gene therapy, and very, very encouraging results. And most of the papers say that, they are going to get approval for curing patients with hemophilia. So, I would just like to summarize by saying that life of patients with hemophilia is changing. Not so much in developing countries at the moment, because access to factor, administration to factor, literacy, the whole practical challenge is a big issue for us. However, I must say that the government and the NGOs are doing a phenomenal job, because we have such a huge population of hemophilia patients, and we are a developing country with limited resources, and that is a huge challenge. But newer drugs are bringing in a revolution in the lives of these patients, and I'm sure that the cost and availability with time will improve and make the life of these patients better. So thank you all for a patient hearing, and I hope this was useful for all of you. Thank you.